Hello everyone. We will talk about introduction to the abdomen. As we know that abdomen is lower part of trunk and it lies below diaphragm. It is divided by plane of pelvic inlet into upper part, which is larger called as abdomen proper, and lower part is called as pelvic cavity. The abdomen is bounded on the large extent by the muscles anterolaterally, and it contains a cavity which is again divided into two. The upper part called as abdominal cavity proper and lower part is called as pelvic cavity. Abdomen contains, in addition to blood vessels, lymphatics, nerves, it also contains two hollow tubular system called as gastrointestinal system and its accessory organs like liver, spleen. It also contains genitourinary tract, and besides this, it contains suprarenal gland also. The abdomen is, organs are contained into peritoneal cavity, which is lined by peritoneum. Again, peritoneum is having two membranes, parietal and visceral. So the parietal peritoneum, in between parietal peritoneum and the visceral peritoneum is peritoneal cavity. We'll talk about boundaries of abdomen. We'll talk about anterolateral abdominal wall, and we'll talk about all the layers of abdominal wall from superficial to deep, just an intro. In abdomen, you will also read about lumbar vertebrae, sacrum vertebrae, sacrum, and you will also read about pelvis. So during this lecture, we will cover competencies. AN 44.1, describe and demonstrate the plane, region, and quadrants of abdomen. And in 44.2, describe and identify fascia, nerves, vessels of anterior abdominal wall. As you can see in this diagram, that trunk is divided by a partition called as muscular partition called as diaphragm into upper part called as thorax and lower part called as abdomen. This abdomen is also divided by a pelvic inlet into the abdomen proper, upper part, and lower is the pelvic cavity. This abdomen, which is visible from outside, is more extensive than what is visible from outside, as upper part of abdominal cavity is covered by costal margin and lower part is covered by the pelvic bones. This abdominal cavity is bounded anterolaterally by the interior abdominal wall, which consists of 6 layers and contains not only skin, superficial fascia, but 3 layers of muscles with their epineuraces, then the fascia transversalis, and then the layer of parietal peritoneum. Posteriorly, it is bounded by lumbar vertebrae and their disc and the muscles which are forming posterior abdominal wall. So abdomen is a cylindrical chamber which extends from diaphragm to the base of pelvis and comprising the abdominal proper and lesser pelvis. That is, the pelvic inlet is dividing the abdominal cavity into abdomen proper and lesser pelvis. It communicates with these two cavities, they communicate with each other at the plane of inlet into lesser pelvis, that is below the upper border of pubic symphysis, and pubic crest and arcuate line innominate bones that is forming the boundary of this. So boundaries of abdomen, it is bounded superiorly by the xiphoid process, which is lying in the base of epigastrium, and then on the either side by the lower border of costal arch, then 11th and 12th rib, on the posterior side, the vertebra, 12th vertebra. Then inferiorly, it is bounded in the midline by the pubic symphysis, then pubic crest, pubic tubercle, then fold. This is groin, with under which the inguinal ligament, and then is the iliac crest and iliac tubercle. Posteriorly is continuous with the iliac bone and then to the sacral bone. In the midline, you can see there is a median depression, a line which is extending from xiphoid process to pubic symphysis, called as linea alba, at the center of which is, you can say, a scar called as umbilicus, which is having very much importance in the landmark of abdomen. We will talk about some functions of abdomen. It not only houses and protects the major viscera, as you can see, all the visceras which are present in the abdominal cavity, which consists of gastrointestinal tract as well as genitourinary tract along with the suprarenals. It also assists in breathing. You know very well that in inspiration, diaphragm which contracts, and along with the relaxation of abdominal wall, it increases the cavity of thorax and thus helping in inspiration, while in expiration, contraction of anterior abdominal wall and thus pushing the diaphragm upward and helping in expiration. And also with this changes that is contraction of intra-abdominal wall, there is increase in intra-abdominal pressure, and it helps in two natural process, that is micturition and defecation, along with an important process that is parturition. Then we'll talk about some of the important landmarks of abdomen. We know very well the floor of epigastrium there is xiphoid process, then this is costal margin, then in the midline below downward, inferiorly is in the midline is pubic symphysis, then pubic crest, pubic tubercle, then from the pubic tubercle extended laterally and upward is inguinal ligament attached to the anterior superior iliac spine, then is iliac bone, and then is iliac tubercle posteriorly. Then we'll talk about that how will we study about organs in the abdomen. That is, from outside, how will we know about topographic relation of organs which are present in the abdominal cavity. So for study purpose, it is divided into 4 quadrants. A line crossing, which is crossing the umbilicus vertically and horizontally, and thus dividing the abdomen into 4 quadrants: upper, right, and left quadrant, and lower, right, and left quadrant. According to another classification, another division is dividing the abdomen or anterior abdominal wall into 9 quadrants, into which 2 lines passing vertically downward from the mid-clavicular point downward to the mid-inguinal point, and 2 lines that is horizontal. One is called as transpyloric plane, which is passing from or drawn from tip of 9th costal cartilage of one side to the other side, and this the line extending from one end to another end, and thus is forming the transpyloric plane. Another plane is called as transtubercular plane, which is the line joining the 2 tubercles of iliac crest from one to other side, and thus dividing the abdomen into 9 quadrants: 3 in the upper region, 3 middle, and 3 lower. In the line above the transpyloric plane, the 3 quadrant, one in the middle is called as epigastric. On the either side are the hypochondric, left and right hypochondric region. In the middle, below the transpyloric line, is umbilical region. On either side are right and left lateral region. And below the transtubercular line is the middle is pubic or hypogastric, and on either side, left and right inguinal ligament. So in the middle, from up superior to inferiorly, is epigastric region, umbilical region, and pubic or hypogastrium. On the left side, hypochondric, left lateral, and left inguinal region. On the right side, right hypochondric, right lateral, and right inguinal region. When you can see clearly in this diagram, 9 regions, although this line, the horizontal plane is not correct, it should be over here, so that this is umbilical, this is epigastric, and this is hypogastric. You can see left hypochondric, umbilical, left lateral, left right lateral, pubic or hypogastrium, right inguinal, and left inguinal. We know these regions, this topographic division of abdominal region into 9 quadrant is important to locate position of organs underneath into the abdominal cavity. Other 2 planes are also often used are the subcostal plane and transcostal plane. This transpyloric plane, which is passing between 2 tip of 9th costal cartilage and is behind or posteriorly, it reaches up to level of L1 vertebra, while this transtubercular plane, which is cuts posteriorly the 5th lumbar vertebra near its upper border. The subcostal plane, which is drawn just at the lower level of the costal margin, and the transcrystal at the up from the tubercles of the iliac crest. So there is transpyloric plane. There are so many structures which are present in the transpyloric plane. For example, the stomach, which is the pylorus part of the stomach, which is related to the transpyloric, that is tip of the ninth costal cartilage. Here is also the duodenum, which starts, and in the plane, it is related on either side. On the left side with the spleen is present in this, and this plane cuts, or in this line, the body of pancreas is also present. Further planes, that is subcostal, which is posteriorly reaching to the upper border of L3, and the supracrustal plane, which is passing through the body of L5. Then we have talked about vertical planes, that is two planes which are passing through mid-clavicle, midpoint of the clavicle to the midpoint of the inguinal. And this is the vertical plane, which is dividing the abdomen into 9 quadrants. You can see positions of some of the important organs in the abdomen. Topographically, we can see from the surface, or we can surface mark liver as extending from left hypochondrium to the epigastric region and extending to the downward to the right hypochondric, and then to again epigastric region. You can see spleen is present in left hypochondric region. Here you can see pancreas is present, extending from a right hypochondric to the epigastric to the left hypochondric region. Likewise, spleen, this is kidney, which is present on either side, left and right. Then you can see the midline is aorta, and on little right to that is inferior vena cava. Aorta, which is dividing into common iliac artery, then common iliac artery, which is dividing again into external and internal iliac artery. Then we'll talk about anterior abdominal wall. As I told you, that anterior abdominal wall is very much elastic and is made up of the layers which allows it to expand during collection of fat, flatus, that is gas, or fluid, and also important, that is fetus. That's why the anterior abdominal wall skin is also very much elastic, and is the anterior abdominal wall muscles and superficial fascia. These are forming a elastic surface, elastic layer, which is allowing the expansion of abdomen during these three: collection of fluid, fat, and fetus. So we'll talk about anterior abdominal wall. From superficial to deep, the anterior abdominal wall is having skin, superficial fascia, there is muscles, 3 layers of muscles, the muscles name is external oblique, internal oblique, and transverse abdominis. And then is this one is fascia transversalis, that is deep fascia of the abdomen. And then is this one is peritoneum, that is parietal layer of peritoneum, and above or in between the fascia transversalis and the parietal peritoneum, there is extra peritoneal connective tissue. So we'll talk about in today's class about skin and superficial fascia. The muscles and other structure would be taught in next classes. About the skin. The skin of anterior abdominal wall is, as I told you, is so that is of undergoing enormous stretching as seen in accumulation of fat, which occurs in obesity, or accumulation of fluid, which occurs in ascites. Fluid is accumulated inside the peritoneal cavity, and this condition is called as ascites, and or in pregnancy also. Then skin of the anterior abdominal wall, we know about Langer's line. So the Langer's lines in the abdomen, they are placed transversely, while of the extremities, they are placed vertically. Why these Langer's lines are important? As any incision in the abdomen is given, if it is along the Langer's line, it would cause minimum scarring. And if it is against to the Langer's line, will cause a bed scar because of hypergrowth of the collagen fibers. So the skin is stretchable and is having all the characteristics as the skin of other part is having. That is having the glands, it is having hair, and it's enormous, is very much elastic and thin. Then one of the important structure present on the skin in the anterior abdominal wall is scar. A scar in the midline of the anterior abdominal wall called as umbilicus, which is formed by fetal and of cicatrized fetal and of umbilical cord. As you can see in this diagram, in the center, in the midline, this umbilicus is present, which is present in 10 dermatome of the and is supplied by T10 nerves and is present at the level of L3, L4 vertebra, in between the L3, L4 vertebra normally, but it may be lower down in the fetus or in the children as the, or infants as the pelvic cavity in them is not very well developed. So this umbilicus, which is present in the center, in the midline at the level of this between L3, L4 normally, and is important as it is having anatomical importance as it is present, it is supplied by T10 now and is present at the demarcate the T10 dermatome, and it is having some other importance also as this umbilicus is acting as a watershed line. Umbilicus the line passing through umbilicus is acting as a watershed line. What does it mean? It means that the arteries and lymphatics which are supplying to this region, they do not cross this watershed line, pass through umbilicus. That means the arteries which are supplying to the region above the umbilicus and lymphatics, arteries and veins also, the vessels which are supplying to the region above this watershed line will drain upward, and the vessels and lymphatics supplying in the lower region of this watershed line will drain downward and will not cross this watershed line normally until unless there is any disease or any obstruction in the draining channels. One of the important one of the importance of umbilicus is, as I told you, that it is supplied by, it is a remnant of umbilical and of fetal and of umbilical cord. It is meeting point of 4 embryonic plates, 2 lateral folds and head and tail folds. It is also a meeting point of 3 systems, namely digestive system, excretory system, and vascular. That means vitreointestinal tract, excretory, that is urachus, and umbilical vessels pass through this during fetal life, and they are cicatrized or they are atrophied during after birth. Then one of the important umbilicus is one of the important site of portosystemic anastomosis. That is, the veins and the arteries which are present around umbilicus and the vessels, the veins, they are present around umbilicus. They are present around umbilicus in the radiating manner because of portocaval obstruction. Another applied importance of umbilicus is that if there is persistent vitreointestinal tract duct, it will lead into fecal fistula. If there is outgrowth, there may be an outgrowth on the surface of umbilicus because of some part of vitreointestinal tract duct is persistent, and this is called as raspberry tumor, as it seems and it appears red. Then there may be a persistent part of last part of vitreointestinal tract. So see, if this is GIT and this is vitreointestinal tract, what is vitreointestinal duct is midgut is having a diverticulum which is passing through umbilicus to the umbilical cord, and this vitreointestinal duct is disappears or atrophied normally, and this is the normal GIT which is present in our body. But if this vitreointestinal duct is present, if its upper part is present at the umbilicus may form a subberry tumor. If this part is present, then it forms the raspberry tumor. If this part is patent and is not atrophic, then this will form enterocele, that is a diverticulum, permanent diverticulum from the midgut, and which may cause obstruction in when during life in human. So there may be after so this is the condition of intestinal tract after birth. This is umbilicus, but if it is not cicatrized in the if a cyst-like cavity, cyst may be present in the center also, which is again causing, there may be a cyst present at the distal line, proximal end, or maybe on the top. And thus, these are of importance in the life. So, this one is enterocele. There may be a raspberry tumor and a Merkel's diverticulum because of a persistent. This is Merkel's diverticulum persistent. This is enterocele, and this is raspberry tumor. Then there may be urinary fistula. Urinary fistula, that is from the this is umbilicus, and this is urinary bladder, and this is median umbilical ligament, which is, if it is present, this is urachus. If it is present, which is replaced by median umbilical ligament in after birth, but if it is present, may cause urinary fistula. Then there may be umbilical hernia, as we know that during development, some part of GIT comes out through the abdominal cavity, from the abdominal cavity through umbilicus into the and this from GIT, and this may remain patent outside, and this is causing eczema fellows, and in some cases anterior part of anterior abdominal wall below umbilicus may be absent, and thus anterior wall of urinary bladder is exposed to the surface, and this is again applied importance of, this is called as extrophy of urinary bladder. So after that, we will talk about superficial fascia. Superficial fascia of abdomen is having two layers, that is superficial fatty layer called as fascia of Camper, and a deep membranous layer called as fascia of Scarpa. The superficial fatty layer is continuous with the superficial fascia of other body parts, that is continuous with the superficial fascia of thorax and in the lower part, that is in the thigh. Then membranous layer of the abdomen that is superficial layer of superficial fascia of the abdomen, which is called as fascia of Scarpa, is continuous lower down with the fascia of perineum. You can see here, this is superficial membranous layer, superficial fascia, that is membranous layer called as Scarpa, which is continuous downward in the scrotum also, in the male, and labia majora in the female. And this superficial fascia, which is present, which is attached on the side with the pubic tubercle, and a line extending down laterally up to 8 centimeter, and thus this membranous layer of superficial fascia, it merges or it fuses with the fascia lata of the thigh here, and in the center or in the midline, it is continuous with the fascia around penis and scrotum. Fascia around penis and scrotum. Behind the pubic symphysis, it is forming a thick ligament called as fundiform ligament. You can see in this diagram, that is, it is continuous from lateral side, that is from the to the medially up to the pubic tubercle, just lateral to the pubic tubercle, and then on the pubic arch and extending to the scrotum and to the around the penis. You can see here this thick fatty layer, which is absent in the penis and scrotum, and this fatty layer in the scrotum is replaced by muscles, subcutaneous muscle called as dartos muscle. You can see clearly here that this membranous layer is continuous with the fascia around penis and fascia around scrotum. Here is the attachment in the infraumbilical part only. This is splitted to form the membranous and fatty layer, and just lateral to the pubic tubercle to the line extending horizontally is attached to the, firmly attached with the fascia lata, and downward to the pubic arch, and then extending to the other side and continuous in, if you will see in the sagittal section, that this is membranous layer which comes downward just in front of pubic symphysis, pubic bone, and is coming continuous in the penis, and from penis to the dartos, to the scrotum, and then posteriorly it is getting attached to the, or is continuous with the posterior end of perineal membrane, and thus forming a, you can say, in front view from the lateral side to the pubic tubercle, and then continuous from either side to the pubic crest and to the other side. And this is in the sagittal view. You can see is continuous with the fascia of same fascia, that is called as fascia, membranous layer or the superficial fascia of the penis is called as Buck's fascia, and the fascia of perineum or scrotum is called as Colles fascia. So the fascia scarpa is continuous with all these fascia, and posteriorly it fuses with the posterior end of perineal membrane or the urogenital diaphragm. What is importance of why we are reading about membranous layer? It's attachment, and why we are talking about that it fuses with this and that is posteriorly and is extending into the upward up to the umbilicus, as if the membranous layer, if there is rupture of urethra in the perineum, urine will extravagate into the below this into this membrane in between the membranous and deep fascia, and may reach up to the anterior abdominal wall, may extend up to the penile urethra, to the penis, to the scrotum, but it would not reach to the thigh, as it would not extend to the thigh, as this membranous layer is fused firmly with the fascia lata, along Holden's line, and thus it would not allow the passage of urine from this pouch to the thigh. So what are the contents of this fascia? It contains variable amount of fat, cutaneous nerves, cutaneous vessels, and lymphatics. We are talking about superficial fascia. So superficial fascia, again, I'm revising that superficial fascia is having a outer thick layer, that is fatty layer, and inner firm and membranous layer, firm and fibrous layer, called as, this is fascia of Kemper, and this is fascia of Scarpa. This outer layer is continuous with the fascia, superficial fascia of adjoining region. The inner layer, that is the inner membranous layer of superficial fascia of anterior abdominal wall, in the infraumbilical region, it is continuous. In infraumbilical region, it is continuous with the fascia around penis and fascia around scrotum. Although this fatty layer is not present as such around the penis and around the fascia in the scrotum, as in the scrotum it is replaced by dartos muscle. While this membranous layer is present in the, is continuous with the membranous layer or the fascia of the penis, called as Buck's fascia, and the fascia of scrotum, called as Colles fascia, or the fascia of perineum. We have talked about extent of fascia from the infraumbilical part to the pubic region, just lateral to the pubic tubercle, at a line drawn horizontally up to around 8 centimeter, and this is called as Holden's line, which around which this membranous fascia is fixed to the fascia lata, and that's why if there is rupture of urethra in this region, or in the perineum will not allow extravagation of urine into the thigh. And this attachment of membranous fascia, that is from the infraumbilical part to the, it is continuous into the fascia of panis, it is continuous into the fascia, continuous with the fascia of perineum, and then posteriorly is extended and closes or fuses with the perineal membrane. We have talked about how this is extravasated to the anterior abdominal wall, to the pelvis, and to the gut. Now we'll talk about cutaneous nerves, vessels, and lymphatics. As seen in this diagram, the cutaneous nerves are branches from the lower intercostal nerves on the lateral side and from the first lumbar, that is named as ilioinguinal and iliohypogastric nerve. And these nerves, they give anterior and lateral branches. So lower intercostal nerves, that is subcostal and T7 to T11, and also from L1, that is iliohypogastric and ilioinguinal nerves, and they give anterior as well as lateral branches. In detail, we will read in next classes. So these are anterior branches, and this is anterior branches are from the upper intercostal, that is 7, 8, 9, and the lateral cutaneous branches are from the and iliohypogastric and ilioinguinal nerve, also supplying the region. Then we'll talk about arteries. Arteries, as I have already discussed, that the vessels, they follow the watershed line rule. The arteries, they are from the upper side, the superior epigastric artery, which is a branch of musculophrenic artery, and from the lower side, the inferior epigastric artery, which is branch of superficial from the external iliac artery, is supplying the anterior region of the anterior abdominal wall. From the lateral side, the intercostal arteries, lower intercostal arteries, they are also supplying the region. And in the inferior part or in the lowermost part of the abdominal cavity, some superficial branches of the femoral artery, that is superficial epigastric, superficial circumflex iliac, also supplying the region. These arteries, they run along the rectus sheath. We have talked about that anterior abdominal wall is formed by is a elastic, fibroelastic, tough fibroelastic covering or layer, which has three muscles into its formation, that is external oblique, internal oblique, and transverse abdominis. One muscle that is called as rectus abdominis, which is running, which is attached, is present vertically, that is from in the midline, and this is supporting the anterior abdominal wall to great extent, and this muscle is present in a sheath called as rectus sheath, and outer border of which is marked as linea semilinearis. In the midline, the muscles of either side, they fuse with each other in crisscross manner and thus forming linea alba. So again, this is superior epigastric artery, this is inferior epigastric artery, superior epigastric artery, which is a branch of musculophrenic artery, and inferior is branch of external iliac artery. Then the lateral, on the lateral side, uh, from the intercostal arteries and the superficial branches of femoral artery. And we'll talk about veins. That is the thoracoepigastric vein and the superficial epigastric vein, which are draining the region. Thoracoepigastric vein is running or connecting the veins from the thorax to the abdomen, and the superficial epigastric, the vessels, the veins, they run along with the arteries. And about lymphatics, again, as the vessels and lymphatics, they follow the watershed line. So the lymphatics above the umbilicus, they drain into axillary group of lymph node. Below the umbilicus, they drain into the superficial inguinal group of lymph node. Like the veins, they are draining to the femoral vein and above to the axillary vein. This is, in this diagram, you can see the thoracoepigastric vein, which is communicated, which is a vein which is present between femoral vein and axillary vein. And this vein, this channel remains dormant until unless there is any obstruction to the, that is, the minimal blood flow is through this vein. So what happens if there is obstruction to the flow of venous circulation? What you see in the normal subjects, this is watershed line passes around along the umbilicus. The veins which are draining upper part of abdomen, that is above the umbilicus to the axillary, and below to the rib. Then what happens in portal hypertension or portal obstruction? Here, as we have already talked about, that in portal obstruction, the veins around umbilicus, they become prominent and form a sun ray appearance, that is radiating veins around umbilicus and giving a sun ray appearance, and called as, this condition is called as caput medusae. And but what happens, what about blood flow of in the veins? Blood flow in these veins in the caput medusae, that is in the portal obstruction or portal hypertension, blood flow is in the normal direction. That is, the veins which are above the watershed line will drain into axillary, below will drain into. While in case of superior vena cava obstruction, these lateral channels, that is the thoracoepigastric veins and other side channels, they and will pass, the blood will pass in these veins, they will cross watershed line and will pass down. While in inferior vena cava obstruction, again these side veins, they becomes prominent like these one, and blood will flow against the watershed line to the axillary vein. So this is again, you can see here very clearly, caput medusae, that is veins prominent around umbilicus, and thoracoepigastric veins are also prominent. You can see in this time. something about inguinal region. You can see here, this is linea alba. This is aponeurosis of external oblique muscle. This is external oblique muscle. This is in growing region. This is attachment of hair would be inguinal ligament from anterior superior iliac spine to the pubic tubercle. You can see this just above this, there is a hiatus called as superficial inguinal ring, which gives passage to the spermatic cord, its covering, and ilioinguinal nerve. And below this, so the inguinal region is the region which is in the groin and extending from the pubic tubercle to the anterior superior spine, a triangle around. This is the inguinal region. This is important, as we'll read in next classes, as in this inguinal ligament, just above this inguinal ligament in the medial half region, there is a canal called as inguinal canal, and which gives, again, you can see here the spermatic cord, and again we'll read about in detail about all these boundaries of inguinal canal, its importance, inguinal hernia, all these are the different layers. You can see external obliquus, internal transverse abdominis. This is spermatic cord. You can see here the inguinal ligament also. You can see the inguinal ligament. This is obliquus, externus, internus, transverse abdominis. This is inguinal ligament. You can see the fundiform ligament also. You can see the spinal, the spermatic cord. This is retracted spermatic cord. So we'll read in all these in the next classes. This was about introduction to the abdomen, or to the anterior abdominal wall. So we have talked about abdomen, abdominal wall, abdominal cavity, important landmark on the abdominal cavity, that is umbilicus, which acts as a watershed line for lymphatics and venous drainage. And umbilicus is also important, as the three system they meet, 4 embryonic folds they meet, and is supplied by 10th spinal nerve, that is T10 thoracic vertebra, and is belonging to 10 T10 dermatome. And so many conditions are related with umbilicus, as I have already told you about the subberry tumor, enterocele, macus diverticulum, umbilical hernia, then about caput medusae, that is in the portal hypertension. So all about the umbilicus. Again, we get question on anterior abdominal wall muscles. We get question on inguinal region is again very much important. We'll read in next classes. But in today's class, we get question on umbilicus. To write short note on umbilicus. We get question on superficial fascia, the fascia of anterior abdominal wall. We get question again, the vessels nerves of the superficial fascia are important. And this, I think this was about today's class. We'll these are some important SLOs, that is define abdominal cavity and subdivide it, and enumerate the abdominal and pelvic viscera, enumerate 9 regions of abdominal cavity, write about umbilicus, planes of abdomen, superficial fascia. This is again very important. So you get question on umbilicus, you get question on superficial fascia, you get question on rupture of urethra, in this region, and why the urine is not extravasated into fascia lata. Plane of abdomen is important, as we'll read about the abdomen in next classes, and we'll read all the structure in relation to these planes or these region or these quadrants. So these quadrants are again very important. And then about surgical importance of anterior abdominal wall, extravasation of urine in perineum, about Cabot Medusae. Yes, we have not talked about domestic reflex. We'll read in next classes, as cremasteric muscle is in the, will read in along with the anterior abdominal muscles. And the paramedian incisions are important, as in case they are given, they will they are mostly preferred, as along the paramedian incision the muscles is only is reflected and not it is cut. So the paramedian incisions are preferred as the by the surgeons, as by the paramedian incisions. The muscles, they are not cut and they are only reflected, so they will heal with the minimum scar. So that was about today's class. Thank you so much.